thank you to all who have hung on and are signed in for today's update. As I've done before, I'm going to spend a little bit of time today talking about the progress we've made on our agency-wide priorities. I'll provide a bit of an update on some of the rate work that we've been doing, and we'll touch on the public health emergency unwind. So I'm going to start first with unwind. As we're talking today, right, we are now over half the way through our 12-month return to normal process. And I'll say it's no small feat. When you look from the time we began in April, that means as of the end of September, we have processed almost 900,000 applications. It means we verified and continued coverage for over 440,000 members. Now, I want to talk a little bit about the progress we've made since we began this work, and particularly focus a little bit on some of the disenrollment part. I know there's a lot of attention on procedural disenrollments, and that is for good reason. I think from our perspective, the worst outcome in this process is that someone who's eligible for Medicaid or someone who's receiving an active treatment for any number of conditions gets disenrolled, and that disenrollment is not because they're ineligible, but because we can't reach them or they're not responding to us. And so if you go back to the beginning and now you look at September here, the current last completed month, you'll see that 54% of members were renewed in September. And that is a substantial increase from the first month in April when that was only around 41%. You'll also notice that most of these renewals are occurring automatically. And what we mean is that means a member is not providing information. It's what we call ex parte renewals. And I mention that here because as a state, we do these renewals at an individual level, not a family level. And that's become a big point around the country and with CMS. Another way of saying that is that we do this the right way, right? We do not automatically disenroll a child if their parents are no longer eligible. And that's important because very often children and adults have different income eligibility levels. Often the children are higher. And that's the way we have always done our eligibility process. And we are really glad for that. Because that means we're not one of 30 states that CMS has intervened in and required them to fix their process. I also want to look at the procedural disenrollment category. If you look at that, you'll see that 19% of applications in September fell into this area. And that is also a big improvement from almost 30% when we first started this back in April. Now, what is responsible for, I think a lot of the improvements that we've seen? I think one thing for sure is that our outreach campaign has been really robust, and I think that has helped get the word out and contributed to more folks responding. So if you just look at the cumulative stats that we have since we began this work back in April, right, so prior to even beginning the unwind, we sent out over 700,000 postcards, and we placed almost 50,000 outbound calls from 211 to members. And since we started the unwind in April, we have sent out over 300,000 warning letters. We've sent renewal packets to over 600,000 members, sent out over 180,000 texts, provided almost 90,000 outbound calls if somebody didn't return a mailer, and similarly 80,000 emails to those that didn't return a mailer. As you can see, it's been a really large effort. And again, this communication effort is focused predominantly on those folks outside of that ex parte renewal, those that we require contact from. And of course, we've not done this alone. We have done this in collaboration with a lot of external stakeholders who have that personal relationship with Medicaid members and who have been able to amplify the importance of returning information and looking out for that information. And we certainly are greatly appreciative of them. This includes stakeholders like Covering Kids and Family, Indiana Primary Care Association, Indiana Minority Health Coalition, providers themselves, our managed care entities and partners, and many others. I am convinced that that collective work that we've been doing has helped a lot more individuals respond to the information we're saying, which means that I'm fairly confident that this effort has resulted in a lot more individuals able to maintain their coverage. And so I also think it's one of the reasons in this work we've done together why CMS has not found deficiencies, why we were one of the first states with no deficiencies in our plan, why we're not one of 30 states that have had to pause or change their redetermination progress. Now, if you want to continue to follow along on our public health unwind work, I would encourage you to go to our new dashboards that are interactive on our webpage. So if you go to our Indiana site and you look down there on the bottom, it'll say click here for CMS reports and dashboards. Then you'll go down to the bottom and you'll click on dashboards. And what you'll see is we've got a variety of interactive dashboards, both for enrollments as well as redeterminations. And so when you click on one of those dashboards, it will give you the ability to look at this work, both cumulatively, if you want to look at all the work up to date, or you can filter by month. You can filter by county if you want to just see how things have progressed in your particular county or a particular county. And you can also filter by demographics. And so this gives you a lot of information for folks that are interested in the impact and how this is rolling out around the state. I would also encourage all of you, if you've not already, to grab one of our new flyers. We started this campaign with reminding people to check their coverage, and we still have those flyers available and out there, but really have also wanted to make sure that we have information out there for those members who have been disenrolled, that they know what they can do to get coverage. And that might be through Marketplace, if they're over income for Medicaid. It could be Medicare if they're the right age, or it could be Medicaid themselves if they are still eligible. Either way, we want to make folks know what is available for them. So by all means, please go to our website. Those materials are there, and please continue to share. It always makes me happy every time I go to my doctor's office or into one of the hospital settings where I go and I see these flyers up there. So thank you all as stakeholders who continue to amplify the importance of this work. I'm going to now spend a few minutes updating you on some of our rate matrix work. Now, by way of reminder, as part of last year's budget bill, or House Enrolled Act 1001, we created in law the way we will establish rates for Medicaid providers who already don't have a rate set in either federal or state statute. Now, the guiding principles behind the way we will do this work, one is we want to create alignment. We want to create alignment across similar provider types, so that we're not driving one type of provider or one type of the workforce into one area. We want to be transparent in this process. We want to involve providers along the way, share how we do the process with them. We want to promote person-centeredness so that our rates are set in a way that also consider the individuals who are receiving those services and what services they may need. We want to reduce disparities across the state and in outcomes, and we want and need this to be sustainable for us. And so to achieve this, we've created a matrix of all of the rates that we set outside of statute, and every one of those rates now will be reviewed on a schedule of no more than 4 years. So no longer will we have rates that haven't been reviewed in 10 or 15 or 20 years. Everyone will be reviewed at least every 4 years. We will set those rates using evidence-based actuarial practices. In between the years of review, we will have a modest index adjustment, so that will help to adjust for increasing costs and inflation. And then when we're done, we take this package and then we can present that to the legislature, who ultimately makes the final determination on how much of the rate adjustments are funded, giving them the ability to balance this also with the fiscal needs and health of the state. Now, for each service category in our rate matrix, our approach is the same. We approach all of this rate work in a similar way. The first rates that we've taken through this process are home and community-based service rates. This includes those for the Division of Aging, our Division of Disability and Rehabilitative Services, for home health. And as you can see here, we're happy to note that those rates have been approved by CMS and have already gone into effect. So really, we're able to really do a lot of work quickly to get those into effect. And it's a really important thing for us, and I think the provider community, because it represents one of the largest, if not the largest ever rate increase for this provider group. And the timing of this really for us is critical and not coincidental, because it will align with our Pathways program, which I'll mention in a little bit, so that we have and can incentivize more home and community-based providers to grow the workforce, to be there as the population we serve continues to age. And while not part of our HCBS work, we are in the process of establishing applied behavioral analysis rates. This is also included in our rate matrix. One of the differences for ABA is that prior to this work, there was not an established rate. So we have now worked to come up with that final rate, which we'll present to the Budget Committee in October with the hopes of implementing in January. And if approved, this would make us, as a state, have the highest ABA rate in our Midwest contiguous states. And then once approved, it would also have that yearly index like our other rates, so that it would continue to increase to account for inflationary and other increased costs between rate reviews. We're also finalizing new dental rates. By way of reminder, CMS has required us as a state to have equal provider rates across our Medicaid managed care programs, and that those have to be in effect by this January. So that means provider and physician and other rates in HIP, Hoosier HealthWise, and Hoosier Care Connect, and we include fee for service for alignment, have to be the same. Now, physicians were addressed in the last session. They were addressed because we created in the House bill that they would be paid at Medicare rates across these programs. Dental services, however, do not have a Medicare rate. And so for us to create alignment, right, first we wanted to look at all of the rates that were done. It has been a long time since we looked at dental rates and adjusted them. So we first do rebasing, and that means we look at everything that we currently pay for. And based on the evidence and the literature, we see if there are changes that need to be made, if there are things that we're not paying enough for, but as we've learned over time, really have a better impact for individuals, decrease the likelihood of developing complications and severe disease or hospitalization, and if there's services that we're overpaying for that no longer really provide that benefit. And so that is called rebasing, and we have done that with our dental rates. They'll have to be equal across our programs. And then the third thing is that we also had to factor in some strategic investments, which equaled around $30 million from last session applied to dental, and how we will apply those. So those three things simultaneously we've been working on with dental. Now we follow the same process as we do with others, and we'll also be presenting that to Budget Committee in October. And simultaneously to doing this, we are already beginning the work on the 2025 budget session rates. And so we will continue to work with many of you and the involved provider communities along the way as we prepare for the next budget session. I now want to turn to give a couple quick updates on our agency priorities. By way of quick background, that includes reforming our aging system so that more Hoosiers who are on Medicaid will be able to choose home as where they want to age. It includes our mental health reform, which involves building a crisis system that is able to both respond to and prevent mental health crises, and involves reforming childcare in a way that will increase the access, affordability, and quality of our childcare system. So we'll start with our aging reform, or what is now called our Indiana Pathways for Aging, or I think many of us just say Pathways for short. Hopefully it's not new to anyone that we have been doing this work. We've begun this now, I think we're in year 3. And really for us, it has got 7 key results that we are focused on achieving so that we can reach our overall goal that 75% or more of Hoosiers who are over the age of 60 on Medicaid will be able to get those services in their home. Now, this involves, a big part of this at least involves moving the over 100,000 individuals who are currently in fee-for-service in this age group into managed care, which will assure better care coordination, better fiscal predictability, and better alignment with Medicare. And this last piece is absolutely critical because as you get older, if you're trying to navigate the services you need as you age, it's going to require you to figure out what Medicaid pays for, if you're on a age and disabled waiver, what that waiver pays for, and what Medicare pays for. And that Medicare part is particularly complicated. But for individuals who are on Medicare and have a Medicare Advantage plan, right, and particularly if they're on Medicare and Medicaid, that Advantage plan is called a dual special need plan, or a DSNP for short. And we know already that almost half of the population that we're talking about here moving into managed care has what we call a DSNP. Now, that allows us to make care coordination much easier because it creates now the alignment so that an individual can have the same health system overseeing Medicare and Medicaid. So now an individual's Medicare and Medicaid, they need something, they can just reach out to a single health plan to ask for help figuring out what services they need and how they can be delivered. Having that dual special need plan is really a fundamental requirement for our program, and it's why Molina has chosen to withdraw from the Pathways plan. They understood the importance of DSNP before our go live date in July, and when it became clear that they weren't going to be able to meet that, they withdrew, which means that we now have 3 managed care plans who we will work with: Anthem, Humana, and United. I will just say for clarification, we're not going to add a 4th. When we initially designed the RFP, we actually did so planning for 3 plans. This is similar to Hoosier Care Connect program, which serves a similarly complex population of around 100,000 individuals. But the scores were so close between the top 4 plans, and the population was large enough that we went with 4 award recommendations. And although we are sad to lose Molina in this, we are still in great shape with having 3 experienced plans that we will continue to work with throughout our readiness review. Another area of our Pathways reform that I want to mention and highlight is around our work to create expedited eligibility process for individuals who need home and community-based services and are eligible for the age and disabled waiver. So the age and disabled waiver also will move into managed care. Prior to the pandemic, right, this process of determining whether you were eligible for the waiver and therefore home and community-based services could be really slow and really cumbersome. And that means it could take weeks, often months, to find out if an individual qualified, and then longer for them to get the services. And for anyone who has had a loved one who is in a health crisis, that's far too much time for many of them to wait for services to be approved. And that delay means that families and individuals choose to go into an institutional setting to get care because it was the best choice. So from the beginning of this work, we recognized that if we could speed up eligibility, right, then we would likely speed up home service delivery, and with that, give more Hoosiers truly the choice to receive services either in their home now or in an institutional setting. And so when the pandemic came, we took advantage of something called an Appendix K waiver to pilot an expedited eligibility process. And this process means that it takes a lot less time to make an initial preliminary determination and to go ahead and get services started while we finish the final determination. Now, we piloted this during the pandemic, and we've been able to take that experience that we learned, and we've been able to apply to CMS to just make this a statewide program and permanent. And I'm really proud to say that we have gotten some conditional approval to do this from CMS. We're the first state to do so. There are some additional things that we have to work through with CMS and get some approvals on, but we're really optimistic that we're going to be able to begin providing this service to select users before we launch our Pathways program in July. So just a lot of really exciting things there. This innovation, this expedited eligibility, was actually highlighted by AARP in the recent scorecard. While it didn't add points to the scorecard, it was highlighted as an innovation that they're going to be looking at for other states to adopt. I do want to mention the AARP scorecard, though, because of the recent release in 23 of the most recent scores. Now, every 3 years, AARP releases this national scorecard, and it includes factors in a variety of different categories. It has a lot of things that reflect how well each state really does at supporting individuals who are older or have a disability. Now, historically, as a state, we've not ranked so well. In 2014, which was the very first year they released the scorecard, we ranked 47th, so in the bottom tier. In 2017, we dropped down to last at 51st. But we have started to see improvements since. In 2020, we improved up to 44th, which got us out of the bottom tier. And then this year, if there was a drum roll, I'd say drum roll, please. We saw a huge improvement. So we went from 44th in 2020 to 27th in 2023. And that is the largest improvement of any state in the Midwest. And so we are really proud of that. Now, I think it's important to mention that this improvement is not really because of one or two specific things. I think it's probably best described as the cumulative result of improvements in a lot of areas. I think really also reflects the states and the governor's commitments and all of our partners, including ARP and the nursing home industry and the hospital industry and others, commitment to improve the lives of aging Hoosiers and those with physical disabilities. I think it's the commitment on all of our partners and stakeholders across the state. Now, I'll mention it's really good to be out of the bottom tier and squarely in the middle, but certainly that's not where we want to finish. And we're going to want to build upon this and continue to see improvements as we work towards moving up on future scorecards. I'll pivot now to talking about childcare. This is another one of our agency priorities. And as we've mentioned in the past, we really focused on increasing the accessibility, affordability, and quality of our state childcare and early learning system. And as achieving this, we have already made a lot of progress, particularly under Director Courtney Penn's leadership. Now, for us, when we talk about accessibility, accessibility really means more childcare seats. And that means that there are more seats available for children across the state, and particularly in age groups, which is that young 0 to 2 age group, and in areas of the state where there may not be a lot of choices. And there's a lot that we've been doing and working on this. I want to mention a couple particular areas that we've done to expand childcare seats. One of them is a $10 million program in grant dollars that we're awarding to current or what will be new childcare providers to either expand the number of seats that they have, or if they're a new provider, to start offering them. These grants prioritize those early children, 0 to 2, as well as children in rural areas where there may not be as many childcare options. We will be awarding those grants very soon, and based on our preliminary review, we anticipate that this is going to add over 1,700 new seats in centers across 19 Indiana counties. So really excited about those grants. And another grant that we'll soon be announcing for folks to apply to is a employer-sponsored childcare facing grant. And this will award businesses and industry or businesses and industries up to 25 million. Well, cumulatively, this will award $25 million in grant dollars to businesses who either want to offer childcare on their business site or near their place of business, or businesses who may want to offer programs to their employees to help offset the cost of childcare. So we're really excited to distribute those grant dollars in a way. I think for us, it's a great opportunity to partner with the business community in a way that we've not done so in the past. And I think that's important because we have that shared goal of supporting their workforce with young children. And we are really appreciative of the collaboration that we've had with a lot of the business community, particularly Indiana Chamber of Commerce, who has been a great collaborator and partner on this work. And we really appreciative of their help, as well as the broader business community. Now, another initiative that we have launched to improve access is that we have changed how we pay with our CCDF program. The CCDF program, or Child Care Development Fund, is a voucher program to low-income families so that they can afford childcare while they work or go to school. We have changed how we pay those childcare providers who take those CCDF vouchers, and we've changed that in a way that will allow those providers to have a more sustainable business model. It really addresses the true cost of delivering those services. And as such, we would anticipate more providers continue in this important field and with this important work, and that those seats continue to be available for Hoosier children. In terms of affordability, we have increased the eligibility level that came out of last session as well for families to receive or to qualify for those CCDF subsidies. So we increased that from what was prior to session, 127% of federal poverty level, to now 150%. And this includes both childcare as well as our pre-K program, which means that more families are now going to be eligible for these subsidies. And I think that, and a lot of the marketing that we've done, we have already started to see some of the results of this work. I think a really exciting announcement that our pre-K program, the On My Way pre-K program, which again provides financial support to low-income families to be able to get pre-K in a high-quality provider. We have the highest enrollment that we have ever had. So over 7,800 children have already been enrolled this school year, and we're still enrolling. And already that's a 25% enrollment growth over last year's school year. So really excited to have that milestone. We're also continuing to work with the Early Learning Advisory Committee and the Department of Education on our quality system and improving that as well, and would anticipate that we'll have some preliminary blueprints and plans for how we might update our quality system sometime here in early of 2024. And lastly, I want to give a couple quick updates on our mental health work, which is another one of our priorities. It is also, I think, as folks know, a priority for the governor and for the legislature. This is a great example of when we all come together, how much we can accomplish and what leaders we can be in a particular field. One thing I'll mention is that in July, we celebrated our 1-year anniversary of launching Indiana 988. And since then, we are receiving upwards of around 3,200 to 3,800 calls per month. And I'm really proud to say that greater than 95% of those calls are answered in state. And that is really impressive, particularly if you look at how this compares around the country, because those numbers routinely put us in the top 5 states in the country. But the call center, as important as it is only one part of our reform. We also know that there are going to be individuals who need more services than can be really addressed with on the phone. And that's why we are increasing the number of mobile crisis teams that we have who can respond in person to an individual. We're likewise making sure that those mobile crisis teams are aligned with a crisis receiving and stabilization unit. And what that means is a facility for somebody who needs more treatment care than can be provided on site by a mobile team. That individual could then be transferred to a location where they really will specialize in helping to address the immediate crisis and to de-escalate that and get them the beginning of treatment that's going to be needed to resolve that crisis. Now, if you go to our web page, there is a variety of resources that are available to individuals in a number of languages. Those are resources that you can use to help increase awareness, which will be really important for us and for everyone around the state. Those are materials that are available in multiple languages. You're also going to see more marketing ads and more commercials reminding everyone out there that 988 is whatever help you need whenever you need it. And so I think combined, all this work is another way of saying that I think we're on our way to really having a statewide crisis response system. An important part of completing that, though, is also work that we're doing now, which is moving towards certified community behavioral health clinic model. This is work that we've begun and would anticipate being finished around 2027. And this is really important because it's not enough to be able to respond to a crisis, but we need a community mental health system that has access and services available to prevent the crisis from occurring in the first place, or to help those individuals who have a crisis get the help they need integrated back in the community so that we are able to make that first crisis their last crisis. And so as part of the CCBHC work that we've done, we sent out an RFI earlier in the summer. We were able to take that information from the request for information, use that, and then have released last week a request for services. And that those responses will really help us be prepared to move to a CCBHC system, including applying for a demonstration with CMS, and finally down the road, a full state plan amendment. So really excited for all of this work starting to come together. One of the ongoing drivers of the mental health crisis is substance use disorder. And I want to mention a couple of things here. I think if you go back to the governor's initial agenda in 2017, he made this his administration's priority, that they would be attacking the drug epidemic. And I think that has allowed all of us across state government and with our stakeholders outside of it to really focus on what we can collectively do to reduce overdose deaths and help more Hoosiers transition into sustained recovery. There is a lot that we've done in Division of Mental Health and Addiction in partnership with Doug Hunsinger and the governor's office. One stat that every time I hear it just sort of makes me proud of Indiana is we distribute 24,000 naloxone doses every month. And we put them in vending machines. We have nalox boxes in buildings across the state. We have expanded our opioid treatment programs. We have worked to continue to reduce stigma on mental health and addiction. And just 2 weeks ago, we announced our new Shatterproof Treatment Atlas program. This is going to make finding providers who can care for individuals in the community as simple as going to a website. And importantly, if we have individuals who need substance use treatment who don't have access to the web or need to be able to call, then they can actually just call 211, and 211 can log into that site and connect them to the resources. Or if they're already on the phone with 988, 988 will also be able to assure that they're connected to a high quality evidence-based treatment provider. So this is truly a no wrong door approach for us and for folks around the state. And I think if you look at the collective work that we've done and the prioritization we've done, we have started to see some of the benefits of that. We found out earlier this year that 2022, our overdose deaths, as reported by CDC, went down in Indiana. We fully anticipate, based on preliminary data, that trend is going to continue into 2023. And while there are still far too many, I think we are starting to see some of that tide turn a little bit, and a lot of this collective work starting to pay off. As I mentioned, these are just a few of the things that we collectively as an agency are working on. We are going to continue in the work we do to compassionately serve Hoosiers in a way that helps to eliminate the inequities that we see so that all Hoosiers can live in fully engaged communities, achieving their greatest emotional, mental, and physical well-being. And for all of you who are really critical and important partners in this work, thank you. And thank you for your partnership. And we look forward to continuing to do the great work together on behalf of Hoosiers across the state. Thank you all and have a great day.